Well, thank you, and good day from Toronto, Canada. My name is John Marshall. I'm a surgeon and intensivist at St. Michael's Hospital and affiliated with the University of Toronto. I'd like to start my presentation with my disclosures, the most important of which being an acknowledgement that the land I'm speaking from is the traditional territory of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas of the Credit First Nation. You can see my other commercial and academic conflicts here. So what I want to address in this presentation is the question of how clinical research and quality improvement interface with each other. We ask the question, when should we undertake clinical research? When should we undertake quality improvement? How do we do it? And are these, in fact, two different approaches, or are there ways that clinical research and quality improvement can, in fact, be blended into a learning healthcare system? Perhaps the best example of this, and one of the most controversial, is the work done a number of years ago by Peter Pronovost when he looked at the merits of a bundle of interventions to prevent central line infections that emphasize the importance of sterility and prevention of infection during the process of central line insertion. He did this through a series of cluster randomized trials that showed very compellingly that the risk of bloodstream infection could significantly be reduced when these bundles were applied. This was designed as a quality improvement exercise and reported as a research exercise to show that indeed the intervention was effective. But it generated tremendous controversy because whereas it was deemed appropriate to do a quality improvement exercise without informed consent from the patients, because of the fact that this was framed as a clinical research program, the Office of Human Research Protection felt that patients had not been adequately informed or consented. There was a long and very complex discussion of the pros and cons of whether this was indeed a research question. And I think it underlines the importance that we have drawn a distinction between research versus quality improvement, which really runs counter to the benefits and the interests of our patients. So research is the process of generating evidence that is reliable and objective about the effectiveness of an intervention. Whereas in classical terms, quality improvement involves the implementing of that knowledge into clinical practice. They are seen as different processes because one is somewhat experimental research. The other one, presumably, is the application of generally accepted knowledge and the increased application, and therefore is seen as improving care. But it's really an artificial distinction. First of all, conventional randomized clinical trials are expensive. They are inefficient and often very slow to complete. So it may take 5 to 10 years from the time a trial is developed to the time it's reported. Frequently, they do not yield definitive answers, or they yield answers which seem to contradict previous research. And perhaps most important, once one has done a clinical trial, one has then to initiate a completely different process to ensure that the knowledge from that trial is taken up into clinical practice. The quality improvement process, on the other hand, assumes that we already know the answer, whereas we know that most of the things we think we understand in medicine, we don't understand entirely, and there's a great deal of uncertainty even in those areas where we do know the answers. Quality improvement focuses not on benefit to patients, but on compliance with a guideline or with a process. And importantly, what a quality improvement process is doing is implementing knowledge that was generated in the past rather than knowledge that is accruing in the present. So the question here is, can we actually integrate research and quality improvement and out of the process create a learning healthcare system? So there is a new model of clinical trial that holds the promise of this marriage of research and quality improvement, and that's called the platform trial. This is a 2-page description of the platform trial. I would highly recommend it for those who have interest in the topic. It's very simple, eminently readable. Critical factors, though, about a platform trial is that you're not studying a disease, but you're studying, or you're not studying intervention, rather you're studying a disease, and therefore you can study multiple interventions. And even more, as the trial goes forward, it learns from what it's doing so that patients are randomized to the arms that are doing better as the trial goes forward. And once the trial is concluded, the conclusions of that trial become standard care for all subsequent patients. So these are the core features of a platform trial. The focus is the disease rather than the intervention. It uses Bayesian approaches. It uses response adaptive randomization, and the results are immediately incorporated into clinical practice. This slide shows how that process works in a trial looking at 3 different doses of an experimental intervention. You can see you start the trial with a 1-to-1-to-1-to-1 randomization, but as the trial goes, guided by an algorithm developed in advance, the randomization shifts so that more patients get the interventions that seem to be doing better. In this case, the standard care, the placebo, and the medium dose. And again, as that goes forward, you can see that those are the ones that seem to be doing better, but that by 1,100 patients, it's the medium dose that is doing better than the placebo dose. And subsequently, all patients who are randomized to that trial receive the medium dose of this intervention as standard care. So you can see how the trial itself is implementing its findings as it is generating those findings. REMAP-CAP is a platform trial that is currently running in multiple countries around the world as part of the critical care response to the COVID-19 pandemic. We are evaluating multiple different interventions in COVID-19 infection in a variety of different treatment domains, including antivirals, immune modulation, anticoagulation, vitamin C, and others. In this trial, we are planning to expand the number of domains that will be studied that will include ventilation, statins, potentially sedation, and even experimental interventions. So what you can see is that although this is a trial that is focused on COVID-19 and an immediate response to an immediate threat, it is a template for a model that could readily be applied to many things that we do in the intensive care unit, and that would enable us in an ongoing fashion to evaluate multiple different interventions and to incorporate the results of those findings into the care of subsequent patients. In other words, to create a continuously learning environment. So here are the differences between research and quality improvement. Research assumes that we don't know the answer, whereas quality improvement assumes we do. Quality improvement includes all patients, whereas research is restricted to those who are eligible and consent. Research, the allocation is random, whereas in quality improvement, all patients receive the intervention. The endpoint for research, importantly, is patient benefit, whereas for quality improvement, it's process change. Knowledge uptake is a separate process in research. It's inherent in quality improvement. And consent is required for research, but interestingly, not required for quality improvement, even though the focus isn't patient benefit, but rather process change. So how does a platform trial then resemble a knowledge translation or quality improvement process? First of all, it addresses a problem rather than a single intervention, and that's really what we think about when we are managing critically ill patients. It increases the probability that the patients who are recruited will receive interventions that are doing better, and it immediately implements the findings that it is developing. Potentially, a platform trial could be a perpetual process that would be limited only by the capacity to collect data and to fund that ongoing trial. And so when one thinks about integrating research and quality improvement, Both are two halves of a coin that melded together would be much better, in my view, for the patient. Greater fidelity to the goals of each, better generation of knowledge, but also more rapid translation of that knowledge, greater potential for patient engagement in setting priorities, greater integration with clinical care, and a more rapid ability to answer the kinds of vexatious questions we run into all the time in the ICU. And particularly important, the promise of integrating research and quality improvement holds the promise of funding that work through health dollars rather than through research funders, and therefore greatly expanding our capacity to rapidly improve the process of care. Thank you very much for your attention.